Wonderful. Good afternoon, everybody. Thank you for joining us for lunch. This is a real pleasure for me. You know, sometimes you have a moment in your life that you remember, you know, when you get to shake hands with somebody who has operated on 22 or 23,000 hearts and saved those patients' lives, that's a real head rush. So I'm really honored, and I'm also honored to share the stage with Dr. Cosgrove, who is really one of the luminaries in American healthcare. He'll probably kick me for saying these things, but that's okay. He's really a luminary when it comes to cardiac surgery, healthcare leadership, and so many other important aspects of healthcare innovation. A couple of housekeeping chores. Full disclosure, I am a patient of the Cleveland Clinic. This is not a HIPAA violation because I'm authorizing you to receive my PHI, those of you who know what that is. The second is Toby is a strategic advisor to MIDAS Healthcare Solutions, the company I co-founded, and I'd be happy to talk about, you know, in a sidebar, kind of what Toby is doing to help us. There is no quid pro quo between those two things, lest you think there is. The other thing, I have to make a bit of a confession. This whole format, and Neil, where's the fireplace? You could have had a virtual fireplace. It's a technology conference. Very good. So Toby organized this program at the Cleveland Clinic for years called Ideas for Tomorrow. And it was essentially a fireside chat, so I'm taking full credit or blame for ripping off the format, but it really worked. So I was happy to see a number of these, and you'd go to a large lecture hall at the clinic, and there'd be hundreds of white coats, and then those of us who don't wear white coats for a living. And Toby would sit and interview some of the titans of healthcare and business who were his friends. And I remember going to see John Doerr from Kleiner Perkins and Ginny Rometty from IBM and Siddhartha Mukherjee, a legend in oncology. And the last one that I saw, I think, was the CEO of CVS, Larry Merlot. And I thought it was a wonderful format, and I really appreciate Toby joining me for this. His bio could take up, you know, all the books that are on the other side of the table, and I commend to your reading the bio in the program. But what's really interesting is Toby's a unicorn. He joined the Cleveland Clinic as a junior attending and rose through the ranks and ran the place for more than a decade. You rarely hear people start at the bottom of a profession and end at the top and have such a successful career. So I think we're all blessed because of that. You know, how many people have one employer for 30 or 40 years? You know, he joined there in '75. I was in 11th grade. So just to tell you. So I have a bunch of questions for you, Toby, and really we want to focus on your career and sort of the arc of where you've been and where you currently are and where you see things. So one of the things I want to ask about, and thank you for your service as an Air Force surgeon. So as a surgeon in the military, and I presume that was during the Vietnam era, is that correct?
It was in Vietnam.
Okay. So how much of being a surgeon in the military during a conflict like Vietnam is innovation, and how much is improvisation?
Well, first of all, let me say thank you very much for having me here. I'm delighted to have an opportunity to speak with you. I'm a little intimidated by these big lights shining in me, but I'll try to make sense out of a couple things. I want to just correct you on one thing. I started at the bottom of at the Cleveland Clinic, but before that I was really at the bottom. I finished my residency and I was unemployed for 6 months. It was very embarrassing for a trained cardiac surgeon to have to go to the unemployment office and try and get unemployment benefits. I didn't do that, but things were getting a little thin, and I'm glad I finally got a job. So it did start at the bottom. So back to Vietnam. One of the things that Vietnam was a great opportunity for me. It started out by the fact that I was in charge of an evacuation facility that had 100 beds and 2 doctors and about 15 nurses and a squadron of physician's assistants. And I learned a lot about from Vietnam experience, which I subsequently transferred over into the Cleveland Clinic. The first was that there's an awful lot of jobs in the hospitals that can be done by people who are technicians and don't have to have a diploma in one form or another. And we incorporated that into physician's assistants in the cardiac surgical suite, and they were the ones who maintained the routines, taught the residents how to do things, allowed doctors to do doctor work, and and so right now you see that the Cleveland Clinic has about 6,000 doctors and about 3,000 physician's assistants. And I suspect that those are going to be very close to being even in the future as we have more and more tasks passed to non-physicians, non-nurses. The second thing that I saw there was that the service had a program where if you got hit in the field, you were taken to a tent hospital where they stopped the bleeding and splinted your wounds. And then you were moved to Saigon or Da Nang or someplace where they had all the specialists. And then you were evacuated to, through my facility, to Guam, Philippines, Japan, etc. And essentially what they were saying is not all places can be all things to all patients. So as a result, and so they had an Air Force to move patients around. And so we established the same sort of an Air Force and transportation system. So every year we move about 30,000 patients by air, by ambulance, fixed wings, helicopters, to be in the right location for the right time, for the right care. As a result, the main campus at the Cleveland Clinic has become a very high-tech place, and in fact, it's the highest acuity of any hospital in the country because we have moved patients who can be taken care of in their community hospitals back to their community, tried to move more patients to outpatient, and reserved the really difficult intensive care requiring sort of therapies to the main campus. So I learned an enormous amount from the service, and frankly, the other thing was it was the first time that I had an opportunity to lead anything at age 28. I got to run a 100-bed facility, which was pretty extraordinary, although I was only in charge of one other doctor.
It's terrific. So the decentralization of non-acute care, bringing healthcare into the population, is that one of the innovations that you created within the time of your leadership at Cleveland Clinic? The family health centers, the express cares?
My predecessor, Fred Loop, started the family health centers, but what we did is we were not an integrated healthcare delivery system when I became CEO. And we had to integrate across the whole system. And for example, we had no common purchasing, no common finance, no common PR, common nursing protocols, et cetera. And so all of that had to be brought into a common working system, which was a struggle over time, but has now proven its value very definitely.
So tell the audience what inspirations caused you to select from all medical and surgical specialties cardiothoracic surgery? What were your inspirations or motivations?
Well, I went to University of Virginia Medical School, and it was in the 60s, and cardiac surgery was just starting. And the physiology and the surgical approaches to it were just being born, and we would go and watch in the dome and watch cardiac surgery. It was pretty exciting. I mean, periodically the heart-lung machine would explode, which was a catastrophe for the patient, but great theater. And so it was an exciting time in cardiac surgery, and I was just drawn to that physiology and that surgery over time, and it was a great ride.
So I understand that you have something like 30 patents that you invented. Could you tell us what your favorites are? Who's your favorite child, if you have one? And whether you can define that by the one that was most commercialized, the one that has saved the most lives, You can pick the criteria.
Well, I think the one that's most fun to tell you about is what we did with the left atrial appendage. It turns out that when patients go into atrial fibrillation, clots form in the left atrial appendage. And so we as surgeons thought, this is classic surgical thinking, if you get rid of it, it won't have that problem. So we would try and sew off the left atrial appendage from the inside, and the stitches would pull through. The tissue is pretty thin. And then we tried to tie it off from the outside, and if you tied it too tight, you'd cut through and get horrific bleeding from the back of the heart, which wasn't a lot of fun to deal with. And then we tried to staple it off, and the staples would cut through, and you get the same sort of bleeding. So one day we're off on Christmas holidays, and my daughters and wife are all sitting around the pool, and I say, okay, girls, tell me all this stuff you put in your hair. The things that go like this, the things that go like this, the things that go like that. And out of that, we developed a clip that goes on the outside of the left atrial appendage that gets rid of it. There have now been 10,000 of those put in without any complications, and the good news is my daughters think they invented it, so they get the royalties.
Do they have their own IP tech transfer council?
Yeah, I'm sure they do.
You have been asked by a number of presidents to run the Veterans Administration. Give us the top 3 reasons why you said no.
Well, there are different reasons. President Obama asked me to run it at the time that the VA was having their issue with waiting lists. And there were about 18 months left in his administration. And trying to change the culture of the Cleveland Clinic when I became CEO, I realized that you can't change the culture of an organization as big as the VA, which has 360,000 employees in an 18-month period of time. So I wrote him a letter and declined the opportunity, but said I was a veteran and I appreciate what veterans did and I would do anything I could to help them. That was a mistake. As a result, they put me on a commission called Commission on Care, which studied the VA and made suggestions to Congress. So for 10 months, I went back and forth between Cleveland and Washington. I learned a lot about the VA. And it was a little stunning, some of the things I learned. For example, there were 130 versions of the electronic medical record, no common purchasing across the VA, very little leadership development, and there was the average age of the hospitals was 50 years, and so I was concerned about the VA, and so knew a lot about it, and when President Trump asked me to take the job, I said, well, I thought I'd better find out what Congress was going to do if they were willing to make significant changes in the Veterans Administration. And so I called with a lot of senators and representatives who were on the various committees, and there was not a big appetite for change in the VA. So I said, I thought that veterans should have their choice between going to the private sector or going to the VA, and I thought it would make their care better and faster. And I thought it would strengthen the VA because it would, in order to survive, it would have to compete. And so I turned that down.
Do you think that allowing veterans to go to private hospitals will ultimately happen?
I frankly don't know. I think it should. I think the VA is set up in a way that is very difficult for it to cover veterans. For example, in Ohio, there are 200 hospitals. There are 3 VA hospitals, one in Cleveland, one in Columbus, and one in Cincinnati. You just can't cover all the ground. And so I simply think that you have a network, and I think you have to remember, though, the VA is the only direct benefit, direct hands-on care that the federal government does for its population.
Fascinating.
And, I think that's enough.
Got it. This is a healthcare tech conference, so let's talk about health tech. So I don't know how many people in this ballroom know that the Cleveland Clinic has a very tight relationship with IBM Watson. Could you discuss that relationship, the significance of it, and what you and your fellow leaders at the clinic would like to get out of it?
Well, so let me say that you all may remember then when Watson came on the scene playing Jeopardy, and Watson was the first of the opportunities that we thought that we could apply machine learning to big data sets. And we spent, IBM and the Cleveland Clinic spent a lot of time trying to figure out how could we use it in education, could we use it in patient records, et cetera. To make a long story short, it didn't work very well. And I think, frankly, the hype of Watson was overhyped at the time. IBM does have a presence now with the Cleveland Clinic around quantum computing, with the idea that it'll be one of the first quantum computers in the country that is applied to healthcare delivery. Well, not so much delivery, but to investigation and research.
Okay, you brought up artificial intelligence and machine learning. Let's talk about robotics. Do you ever foresee a day when surgical procedures will be performed exclusively by robotic-driven systems? You know, this is personal to me. I'm full disclosure, here's another HIPAA violation. I'm having a total knee replacement at the clinic by one of Toby's partners, and it's going to be robotically assisted. So I have a vested interest in learning about robots in the operating room. You ever see a day when your technical knowledge and hands will be replaced by a machine?
I can't believe that we're going to have total robotic intervention. I think one of the things that I always was concerned about with robotics is every now and then you get a bleeder, something that squirts on your lens, and to not have somebody there as an individual to deal with those sorts of situations, I think is difficult to conceive. I think they're going to have an increasing part to play in assisting surgeons, and it will get better and better and better as time goes along. I've seen several innovations that will assist surgeons, but in terms of putting together a motor at GM like that they do, I don't think you're going to see that. And the main problem is people are all a little different. So I'm not excited about the potential for total replacement of a physician.
Let me ask you a related question. There are certain disciplines in medicine that are vision-based. Think radiology. Think a radiologist sitting in a dark room looking at shadows and trying to compare that image to variants of normal or variants of abnormal. Is there a use for things like artificial intelligence and machine learning to either enhance the subjective practice of radiology or perhaps someday replace it?
Oh, absolutely. And I think it's here right now. I mean, you look at the first place we saw it was in dermatology, looking to try and predict the differences between a melanoma and a nevus. And they outperform the dermatologists. And certainly there is a number of companies which are far along in using radiology and using artificial intelligence in all aspects of radiology, whether it's neuro and looking for stroke early interventions, or whether it's on reading chest x-rays or mammograms. those are all real aspects that are, and even if it just goes to the fact that you are, and by the way, I think the same thing can be said for pathology. They're going to be able to read slides with more speed and probably greater accuracy than a pathologist can. So I look for those things to be part of our regular practice in the next decade.
I remember going to a presentation with the, I think it was a medical legal group in Cleveland when you got your first 2 MRI scanners on 105th Street. And at that point, they were called NMRs. And people used to joke around and say NMR didn't stand for nuclear magnetic resonance, it stood for no more radiologists. So it's kind of an interesting thing. So let's switch over to challenges in healthcare, not related to the VA necessarily. There are lots of things that are going on in healthcare now that are presenting challenges. Staffing shortages, increased demand, decreased access, increased costs, decreased reimbursements, and things like, and this is a news story this week, resident physicians unionizing. So in the last year, the residents at the hospitals at the University of Vermont, Stanford, USC, and Cedars-Sinai voted to unionize. And in fact, the residents at Cedars-Sinai last week went on strike, effectively shutting down healthcare services at those hospitals. So tell us, what are the biggest challenges from that list or others as you see them in the next 5 years?
Well, I think there are 2, and I think they're both critical right now. First of all is the one in labor. We've seen a huge exodus for support in the hospital. In fact, at one point, not too long ago, the Cleveland Clinic across its system had 450 beds closed because of lack of nursing. It is, in order to look after the nursing shortage, it is estimated that there will need 250,000 nursing graduates a year. And I think the chances of that happening are slim and none. And so the issue in that respect is, how in the hell are we going to manage the hands-on aspect of delivering care with a shortage of individuals? And clearly, I think this is where technology is going to have to step in. Let me tell you about one piece of technology, and I think you'll appreciate where this could potentially help. This is a thing called biointellisense, and it has a button about the size of a quarter that you stick on your chest. It gives you blood pressure, heart rate, respiratory rate, oxygen, motion, etc., all the vital signs on a continuous basis, and puts it straight into the electronic medical record. Now, there's a couple of things that come from that. First of all, the good news is you're not going to get awakened in the middle of the night by a nurse coming in to take your blood pressure and your temperature. And it's so that will reduce nursing work. Second aspect of that is you're going to be able to monitor people and get them out of the hospital sooner. The third aspect of that is you're going to create a heck of a lot of data. And one of the things that you're always concerned about is somebody going into septic shock. But you're going to see the potential for that happening way earlier, whether it's using artificial intelligence, whether it's the respiratory rates going up, or whether our heart rate's going up, or a combination of those sorts of things long before the temperature starts to go up. So I think, excuse me, I think there's an enormous requirement for technology to begin to step in and replace a lot of the labor that goes on. And I would say that's not just the place that's going to happen in the clinical care, it's going to happen in the support aspects. And that means the Cleveland Clinic has 2,500 people who work in revenue cycle. You ought to be able to read the chart, read the diagnosis, read the payer, and put the bill out in about 2 nanoseconds. The other thing is making an appointment. And you stop and think about call centers. The Cleveland Clinic has 900 people working in call centers. These people have to be trained. They last about a year, then you got to have a new group. And with natural voice recognition, you ought to be able to take care of a lot of that. And that's already happening with a couple of companies I'm aware of. One's called DexCare, which is now taken over, doing a lot of that thank you very much. A lot of that for Kaiser. Then there's another company called Notable doing the same sort of thing. So these things are all in the works to begin to reduce the number. Now the second issue, and this is frankly a crisis, and this is going to affect what's going on right now, and that's called inflation. The cost per patient care, just on the basis of labor, is gone up 19%. The cost of supplies is gone up 21%. And the cost of drugs is gone up 35%. Now remember that you have to understand that you're now dealing with a system where going into this, 20% of the hospitals in the United States were running in the red. And they've all been adversely affected by COVID. And you're not able, when you got about 60% of the patient's pay comes from Medicare and Medicaid, which doesn't go up with inflation, you've got a crisis for how the finances of the hospital are going to work. And you probably saw recently that in the first quarter of this year, Cleveland Clinic lost $300 million. And this is not the only place that's suffering. So, and there are the rural hospitals. There are 148 rural hospitals that have closed in the last couple of years. And I think we're in a serious crisis that has not yet been recognized, the magnitude of it. So to put it in perspective, the margin on the Cleveland Clinic runs on it every year is 2%. And a hospital that's doing really well gets up to 5 to 6% margin. That gets wiped out pretty quickly by those sort of inflation numbers. So I think we're dealing with an enormous crisis here. And I think the concern is not that, and how do we deal with it? The concern is that services start to deteriorate. And services get eliminated to try and make things work financially. That, I think those two things are the real crises that are affecting our healthcare in the foreseeable future.
Terrific. Let's talk about physicians as entrepreneurs and physicians as innovators. So at this terrific conference, Neil, it's just been phenomenal. There's so many innovators and entrepreneurs and thinkers and doers, but very few of them are physicians. And this is a healthcare tech conference. So in getting ready for this meeting, I pulled an article from Stat Medical News, and if you don't know about Stat, you should get a subscription to it or pay attention to it. It is the best curated medical, life science, tech stuff. It's all coming out of Boston. It's really phenomenal. And there was an article published last week by a physician at Mass General Brigham, who's also part of their innovation team. And it's called Immersion in Innovation Should Be Part of Every Healthcare Professional's Training. And it reads, I'll read you a little quote, and I want to get your response while you're rehydrating over there. When it comes to fostering innovation, most academic medical centers, medical schools, and health systems use the pull approach. They open technology transfer offices, hire staff, create industry relationships, and then wait for physicians, investigators, trainees who could be students or residents or fellows, and other healthcare providers to initiate contact, submit new inventions, and navigate the typically opaque path of medical innovation and discovery. This article suggests the following. There's a better way. Pushing fundamental health innovation knowledge, skill sets, opportunities, and ground level support to every healthcare professional who enters the doors of an institution. This article estimated that the number or percentage of bona fide innovators at Mass General Brigham, another top 5 hospital, is, wait for it, 0.5%. So you'll see their ads on television, they're on lots of sporting events and things, and they keep saying, we're the innovators, we're the innovators, we're the doers, we're the thinkers. But less than 1% of their caregivers actually do any sort of innovation. And the reasons cited are lack of time and energy. So with the production pressures on healthcare providers, how do we get really talented physicians to become innovators and entrepreneurs?
Okay, so this is, I think this is a systemic problem. And the systemic problem starts with how you get to be a doctor. You get to be a doctor by getting through organic chemistry, which has no original thinking going on. It is pure memorization. Then you go to medical school, and certainly there's no original thinking going on there. And then you become a house officer for 4 or 5 years, and you are punished for doing anything that is not by the book. And then you become junior staff, and the same sort of punishment is meted out to you if, in fact, you deviate from the standard of care. And so as a result, from a new technology being demonstrated to be effective, it is 13 years before it becomes standard of care in the United States. And that hasn't changed one whit in the last 30 years. So essentially, if you don't learn it in medical school and you don't learn it in your residency, you're probably never going to practice it. Because 13 years is almost the half-life of a doctor. I think that in order to change this, you've got to figure out how you begin to select people who are going to go into medicine by doing something other than just having them get through organic chemistry. It'd be nice to have someone who is taking a course in creative writing or art history or philosophy or something of that sort and demonstrated their capabilities, because certainly organic chemistry is not, they should not be the gatekeeper for people who think and going into healthcare. So I am, and there's no encouragement to be innovative. And one of the interesting things about the Cleveland Clinic is I went there and I found it incredibly different than what I found in Boston. At Mass General. There was a tradition there of crazy people with crazy ideas being tolerated. And, that the first dialysis machine was made with cased sausage, sausage casing. The first intra-aortic balloon pump came there. The first coronary bypass, the first G-suit for shock. The founders of the Cleveland Clinic used to go and study the heart rate of whales. So there was a curiosity and a tolerance for people with different sorts of ideas that I didn't find in Boston, and I gravitated to that simply because of the culture. And I think you have to cultivate that culture because it's a very tenuous, very fragile culture. And if someone comes up, for example, I know a doctor who got fired because he had the idea that he could take a gallbladder out through a hole in the stomach endoscopically, and did it successfully and got fired. And so you have to be open to allowing people to do ideas. And I'll tell you one of the examples of that. So I was interested in reducing the amount of blood that patients got in cardiac surgery, and so we wouldn't transfuse them until they got as white as the sheets.
And I got called in to Mason Sohn's office, who was the guy who did the first coronary angiogram in the world. And he said, Toby, what the hell are you doing here? And I said, Mason, you didn't understand what you're doing when you did the first coronary angiogram. I don't know what I'm doing here, but give me a chance. He said, okay, no problem. So that's the kind of tolerance that I think you have to have in an organization to encourage innovators to do new things.
Let's talk about leadership, because leadership is at its core innovation. Let's talk about women in healthcare leadership. What are your greatest accomplishments in this regard? And when will the Cleveland Clinic have a woman physician CEO?
Well, I mean, they now have the first woman chief of staff at the Cleveland Clinic. So let's talk about the bigger deal in leadership. And then I'll go on to women and that aspect of it. You know, we all are trained essentially to be technicians. Nowhere along the way do you get any sort of training in being a leader. And so I began to think about, okay, how do you train leaders? Because I recognize right away that the importance of an organization's to get great was to have great leaders at almost every level. I recognized that you put the right leader in on a nursing floor, the nursing floor went from terrible to good in about 2 weeks. I recognized that when you put the right president of the hospital in place, the place got better in about 6 months. So I said, boy, if we're going to grow this organization, going to have a great organization, we got to have great leaders. So I thought, okay, who trains great leaders? And it used to be Procter & Gamble, or you went to McKinsey, you went to GE. But what organization, what group has been thinking about growing leaders for a long period of time and really studied it? Well, my conclusion was it was the military. They've been thinking about making leaders for centuries. And they have a very simple model when you stop and think about it. Their model is that they wind up giving people graduated experience over time. And if they do well, they get a bigger group to lead. And if they do well, they get a bigger group to lead. So I tried that. I put a bunch of docs in charge of hospitals, and some of them did well, some of them didn't do well, some of them got bigger hospitals. And then the other thing that the military does is in between these various situations you have, you're sent to get the academics. Some go to Harvard Business School, some go to the Naval War College. They go to all different things to get their academics to move up the chain. And by the time those guys get those stars on their shoulders, they're damn impressive people. And they've been trained in leadership, and they've thought about leadership, and they understand about how you pick leaders, et cetera. So we don't do any of that in medicine. We just think that docs come out, they're great in organic chemistry, and they've gone through all the hoops, and now they ought to be leaders. And just because they've written more papers than anybody else, they ought to be able to step in and be able to be great leaders. Well, I've seen that fail. And just because they have run a great lab doesn't mean they can be a great leader. So we started a program where we take docs, and when I left, had about 250 docs in some sort of leadership position. And so the example that I would tell you that is my successor. My successor is a cardiac surgeon who came to me and said he wanted to be more and have more of a leadership position in administration. We sent him to Harvard Business School to get an executive MBA. Then we sent him to the desert. He went to Abu Dhabi, where he was chief of staff, and then became CEO, and now he's CEO of the Cleveland Clinic. Better trained than I was, smarter than I was, and nicer than I am. And by the way, there are now 6 people who worked for me who are now CEOs of hospitals. And I think that we as physicians, have got to think about training leadership. Now, back to women. You know, I was trying very hard to find women to put into one of these leadership ranks and wanted her to be head of a hospital. And I called her in and I said, listen, I think it's time for you to go and take that. No, I'm not ready. You know, I don't know this, I don't know that. Well, how many guys would turn down that kind of opportunity? And I think that, you know, when given the opportunity, women are frequently reluctant to step up, feeling not quite qualified. Guys would look at it as a challenge and take it on. And so I would encourage women, when given the opportunity, to seize it, because you're never going to be ready. Man, I'll tell you, when I got to be CEO, I didn't have the slightest idea what I was doing. I can tell you that I'd never been to business school. You know, it took me about 2 years to figure out those parentheses and P&Ls. Those aren't good. It took me, but I had no hesitation about jumping right in. And similarly, you know, I think that that's one of the things that women have to seize the opportunity. And if you talk to Ginny Rometty at IBM, she'd tell you exactly the same thing. You can't wait till you're perfectly prepared. You have to take the opportunity.
Your first chief patient experience officer was a woman, correct?
She was. She was not quite ready for the job. And didn't last very long.
Sorry I asked. That wasn't on the script. I'm going to ask you a couple more questions, and Neil, can we open it up to the audience for a few questions? Okay. Part of being a healthcare leader is making bold moves that aren't necessarily popular. And I'm not talking about HR moves. I'm talking about things like this. You decided that we take care of people's hearts who eat too many Big Macs. And we have a McDonald's on campus. So you got rid of McDonald's. But you kept the Starbucks. You made the campus non-smoking. And you took munchies and soda out of vending machines. So as a physician leader, how do you deal with public or within your own ranks repercussions or pushback from big decisions that might not be necessarily popular?
Well, I can tell you why I did it. I can't tell you how you deal with the pushback, but you have to be a little persistent. So I felt that, you know, I think one of the things we've learned out of this pandemic is the importance of the social determinants, and part of that social determinants is what you eat and how you take care of yourself. And I didn't think we could talk about the dangers of cigarettes and have doctors smoking outside the entrance of the hospital. Similarly, so I thought we need to model what is the appropriate care, and that involved a couple things. It involved, first of all, no smoking on the campus. Then we decided to stop hiring smokers. And then we did the whole thing with food, and then we did a whole push on wellness for our employees, which is expanded life expectancy and cut costs enormously. And then the final thing that I did, is it took me a long time to screw up my courage for this. We did random drug testing on everybody, including yours truly. And by the way, that's not why I stepped down. I passed. But just to put this in perspective, we're the only hospital in the country that does random drug testing for its employees. Imagine that. I mean, you have to get to drive a Caterpillar tractor, you have to get drug tested, but not to do a heart operation. So
should that become a standard across the country?
Yeah, I think it should. I absolutely think it should. You know, and we know we had, per our previous discussions, we had at least 5 deaths in employees in the hospital from either stealing drugs or using drugs in our facility. So we know we had a problem.
It's that lack of self-awareness among leaders that prevents solutions from actually working. So as a corporate executive in my company, I look at leaders in different areas of business and culture and the like. And I try to study where they came from, not necessarily what business they started, but kind of how they were formed, not in the embryo stage, but shortly thereafter. So I'm going to read off a list of names, and then we're going to talk about what is common among them. Steve Case, and if you're older than 50, he sent you 10,000 America Online CDs over a 10-year period. Chairman of AOL and then Time Warner. Edgar Bronfman from the Seagram's alcohol company. Herbert Allen, anyone in private equity or investment banking will know Allen and Company. They're probably in 75% of the major deals around the country. Stephen Sondheim, the greatest composer in Broadway history. Michael Beschloss, a noted historian. George Steinbrenner, who started in Cleveland, and they bought this little group of ball players called the New York Yankees. And Toby Cosgrove. So many household name leaders have one thing in common: their leadership in science and culture and business and history. They're all graduates of this little school in Western Massachusetts called Williams College. It's probably the best little school that not everyone has heard about. So my question is, to what do you attribute your success and the successes of these other luminaries, fellow Williams grads, who go on to their incredible careers? Is it the rarefied air in the Berkshires? Is it how they teach motivated students who have an eye on some prize years away? But what is it, sir?
Well, thanks for the plug. I don't deserve to be in that same category, but those individuals. But, you know, Williams College is a unique place. I had a terrible experience there as a student. I was, just to put in perspective, I think what Williams did for me was teach perseverance. It turns out that I'm dyslexic. And I didn't know I was dyslexic till I was 35, and I got to Williams, and they wanted me to read a book a week, and in French. I got in remedial French. Well, my French class started, but the first day I walked in, there was they were saying "Oui, oui, monsieur," and I'm looking up and down the page for "we." It's not there anyplace, and I knew I was in trouble right away. They put me in remedial French. We met 5 days a week at 8 o'clock in the morning, and I got 3 D minuses and a D trying to understand where we was supposed to be spelled. So I survived, and it taught me perseverance. Now, the group of people there that I always talk about is they're the most diversely talented group of individuals I've ever met. And I think part of the reason is there's a sense of humility about the organization that is symbolized by its mascot. Its mascot is not a lion or a tiger or an elephant, it's a purple cow. So the place has a sense of humor about itself and doesn't take itself too seriously. And as a result, Forbes magazine picks it as the #1 undergraduate school in the country, ahead of Harvard and Stanford, et cetera. So it's a unique environment. It's a little bit like training with the Marines at Quantico.
In a much nicer physical environment.
Yeah.
So I could ask questions all day, but Neil will shoot me, and because I'm getting off of schedule. So why don't we open up to questions from the audience for a couple of minutes? Neil, would you like to moderate this portion of this? You could take this. If anyone has a question for Dr. Cosgrove, not for me, raise your hand. And very impressive. I'm taking off my jacket. Thank you. A little too late, Neil. Yeah, if you could stand up and identify yourself so we know the context of your questions, that would be great. We can't see anybody, so. Can we turn up the house lights perhaps? And turn down the fire? It's getting warm in here.
I'm Cosgrove. I think added to the group, I believe his college was President Garfield. I think he took his undergraduate training there.
Yes, he did.
Dr. Cosgrove, healthcare disparities. Any comment on possible reach of some remedy?
Yeah. Yeah, this is a tough one, and it clearly has been brought to the fore by the pandemic, which has demonstrated the difference that we have. And I think the disparity is probably overshadowed by the social determinants of health. And if you stop and look at the social determinants, whether it's education, job, housing, food, those have one common denominator, and that's been poverty. And one of the things that I got quite involved in was United Way in Cleveland, for years that they've always tried to put a Band-Aid on whatever the problem was, whether it's food or housing, et cetera, and they're really looking at trying to look at the root causes of poverty. And one of the things that they pointed out was that 50% of the kids in Cleveland have lead in their blood. And as you know, lead decreases neurologic function, damages the brain early on, which leads to not doing well in school and not doing well getting a job and not doing well in the job, et cetera, et cetera. So the Cleveland Clinic recently just gave $50 million to United Way to deal with the lead issue. So I think ultimately we're going to have to address these disparities by looking at the social determinants that we have that are part of and parcel of that, the disparities in healthcare.
I noticed they're putting hot dogs and marshmallows in the lobby for after the talk. Any other
No
questions?
smears? No smears?
No s'mores.
Maybe one last quick one, if there's any other interesting questions.
Dr. Cosgrove, how important do you think it is for a health system to be led by a clinician versus somebody like you?
Yeah, so a couple of things I would say. My predecessor used to have a saying that it's easier to teach a doctor business than it is to teach a businessman medicine. And I think there's some truth to that. I mean, it's glib, but there is some truth to that. And I think some of the proof of that issue is the fact that hospitals led by physicians across the country have higher quality outcomes than do business-led hospitals. Just a fact. So I think that if we can begin to train more physicians in leadership, I think that the healthcare system would improve initially. And frankly, if I would point out some of the deficits of the national health system in England, it is all run by administrators and with no physician leadership. And I think that is a deficit that they pay highly for.
I think we're into overtime. Please join me in thanking Dr. Cosgrove for this terrific conversation and for coming down to this conference.
My pleasure.